Dr. Mark Bartiss. He's from New Jersey, a lot of places in New Jersey. I have to read it. Manahawkin, Wayne, New Jersey, and Medford, New Jersey. So if you're watching and you're anywhere around there, this is your guy. Hello.
Hi, Suzanne.
We have met before at conferences, and I always admire doctors such as yourself who have stepped out of that comfortable allopathic standard of care box to go into this new way to treat patients, because I know you take a lot of flack from your peers, but all I can say is that I am very grateful that you're out there doing what you're doing, because I think that what you're into is a real game changer in aging. There's a new way to age, isn't there?
There is.
Yeah. And would you say that bioidentical hormones are probably the first line of defense in aging the new way?
I would say that, yes, but it's not enough. There's much more, but it's absolutely that's important stuff.
So let's get into in a minute the it's not enough part. Let's talk about, because you talk about different ways of administering and the pros and cons of various forms of hormones. So let's talk about what are the pros, what are the cons?
Okay, I'd like to start out asking you to try to live this ICAM experience. I want this to be like as if you're sitting in front of me and you're actually a patient. So you can feel my energy and see what I do and what I say to my patient.
Okay, all right, I'm your patient. I'm your patient.
There you go. So you're my patient. Now I'm going to try to do some slides. We'll probably have to edit these, so I'm not quite sure. So here's what it is. The important thing I would like to say, you've excellently done the difference between bioidentical and the non-bioidentical hormones. Explain it. It's a matter of semantics, but I think it's really important to differentiate bioidentical hormones and the non-bioidentical. To say synthetic is not really a good way to use that, because synthetic simply means it's man-made, right? All of them are really man-made. So if we really want to make an impact on our conventional colleagues, we really have to be exact about what we say. It's, again, semantics, whatever. So I like to refer to as the bioidenticals being BHRT, and the non-bioidenticals HRT. And if you want to say estrogen receptor therapy ERT, that's fine. But I think it's really, we'll call it BHRT and HRT. I think it's a better way to describe the terms.
Okay.
Okay, so go. I'm sorry.
Nope, you go. I'm the patient.
All right, good. You're the patient. That's right.
Yeah. I'm very obedient too.
So what I do is I have patients when they come in, and I get a history and physical examination. My first visit's about an hour and a half, 2 hours long, and I get this obtain the history. And then what I do is I say, today is going to start to learn something right now. And the first thing I want my patients to learn is to realize there's a difference between what's called normal and optimal. And I have a slide here. I'm going to try this, and if it's not, we can edit this, right?
I'm excited.
Okay. So.
Because you have your own IT guy there.
Yeah, we have.
Okay. Institute for the Complementary and Alternative Medicine.
Okay. Now what you see there, I hope, is a slide there that says difference between normal and optimal.
Correct.
Now that little graph there, you see high and low ranges. These are the normal ranges for any type of lab test. Now, if you are low and you're number 1, and if you are 10 as a high, and those are the ranges, and you're a 1.1, then they consider you as being normal. But it's probably not optimal. Now, optimal is not based on these really reference ranges, because we know that 5 to 10% of the people, actually 10% of the people who are, quote, normal, fall within these ranges. So I like to set this home by saying this. We have a little daughter, Susie, and she comes home final day of school, 6th grade, last day of school, and her final grade on the report card is a 2. Now, a 1 is passing, a D, and the A+ is a 10, and she has a 2, when knowing that 5 is the midline. Where's she going for summer? Disney? I don't think so. So there's a significant difference, right, between normal and optimal.
Right. And
optimal isn't the same for everybody, and it's not based on these reference ranges. In my practice, it's based on, get on this line, it's based on not the absence of symptoms, because we know the absence of symptoms or the absence of dis-ease doesn't mean the absence of disease. I had a guy come in to me today, stage 4 cancer, no symptoms. He was referred to me today. So just the absence of dis-ease doesn't mean the absence of disease. Okay, so with that being said, how do I determine optimal? It's based on sometimes the presence of symptoms, but certainly more importantly on how one lab test affects another. It's called, conventional medicine. No, it's not called that. It's called integrative medicine or functional medicine. We look at how one test affects the other, and that's how we determine optimal levels in my practice. Now we'll talk about these bioidentical hormones. I'm sure you get asked all the time, are these bioidentical hormones safe? And I answer the question like this, and you're going to love this. You're going to put this in your book, guaranteed. Go ahead. Let me see the next slide.
My pen.
And you're welcome to use any of these. These are really cool.
And I will.
Okay. Next slide, please.
By the way, while he's getting that slide, I would imagine one of the things you're talking about is a lot of men will go in and have their testosterone levels tested, and they'll say you're normal. But normal for what age? Normal for a 75-year-old? Do you really want to have a 75-year-old testosterone?
Exactly. And one more thing with that, Suzanne, it's very, very important, and I'm not sure if you're aware, of the other listeners are aware, but the levels of testosterone in both men and women, regardless of how old or young we are, regardless of what bodily fluid is used to measure, blood, urine, or saliva, between the hours 2 in the morning and 10 in the morning, if your test was obtained in that time, whatever number you have, divided by 2. Again, because the levels are double between those hours. Think about it. A young man, 30 years old, spontaneous erections because those levels are that high. Now, as we get older, like me, I celebrate when I get those. But the bottom line is that those levels really double. So you have a young man come in it's 50 years old, 40 years old, and his levels at 8 o'clock in the morning are 900, which is in the range 8 to 12. He's really 450.
I got
so
it.
Joe is really Josephine. Yeah. Okay. Now, these bioidentical hormones, are they safe? And I like to show that same graph that I show you, high or low range here. And, okay, I ask the patients, I'll say, you're going to the eye doctor and draw a big E. And they draw a big E here, just like you see here. Are you seeing this graph here?
I am.
Okay, good. And this is estrogen. I tell them this. The number 1, 2, and 3 cause of death in women in America between 25 and 50, depending on the decade there, is breast cancer. And that's not caused by the non-bioidentical HRT, Prema, and Prempro, because they're 25, 30 years old, developing breast cancer and dying from it. So what causes it? Okay, so here's your estrogen. But in relationship to the amount of progesterone and testosterone that you see here, the teeter-totter looks like this, not like this. We call that estrogen dominance. Now, what causes estrogen dominance? Okay, so estrogen dominance starts in early life. I have a daughter who's 26 years old. She's a professional athlete, has very low testosterone, at 27th in the world, is a Spartan runner. When a woman turns 19, 20, 21, they start dropping their testosterone level. So the teeter-totter is already starting to angle. When they're about 25, 30, they start losing the progesterone. All of those things adding to that estrogen dominance. How long had they been on birth control pills? Xenoestrogens coming from the plastics we're cooking in the microwave, out of the water bottles that we're drinking. The pesticides, the non-organic foods, all these things over time cause these problems with this estrogen dominance. It's years, cumulative effects. So this is what the big problem is. And now they ask me, okay, Mark, so if I balance estrogen, progesterone, testosterone with these bioidentical hormones, will I decrease my risk of heart attack, strokes, colon cancer, Alzheimer's, Parkinson's, and osteoporosis? Now, I said that, so I say that millions of times, and sometime I hope we get the opportunity to talk about at one time that I was an international advocate for Premarin. I'm going to go to hell for that, and someday I'll be able to talk to you about this. Time now, but,
don't worry, I have my own sins. We'll hold hands.
Oh man, let me tell you, it was terrible, terrible. Okay, so I say yes, if you balance your estrogen, progesterone, and testosterone with your thyroid hormone, your adrenal glands, your neurotransmitters, a program that I have called HEART, someday we could share that perhaps, you truly decrease the risk of heart attack, strokes, colon cancer, Alzheimer's, Parkinson's, osteoporosis, mentally, emotionally, physically, sexually, globally feel better. What's wrong with that?
Right.
Right? That's
I wish, to interject for 1 minute, I love, first of all, for all of you watching, here's a doctor, first time you go in, he's going to give you a couple of hours. This is like right there. Just pay attention to that. But when I had, when I had breast cancer.
Plastic.
Do notice, no glass.
All right.
I no phthalates for me. I don't drink.
There you go.
When I had breast cancer, I wish I had known what you just said, because I was estrogen dominant. So the first thing that I was told was I can never take estrogen again. I didn't understand at that time that estrogen dominance for me meant my body just wasn't making any progesterone anymore. And that's what all those moods were about. That's what all that weight gain was about. That's what all that bloating was about. That's what made me feel like I was a crazy person. So just the fact that you understand that, because there's so little understanding of estrogen dominance. And I know so many women my age who have been told they can never take estrogen again, so they suffer through the rest of their life when the information is wrong. Continue, doctor.
Okay, Mark, please.
Okay.
Okay, Now, the various forms of bioidentical hormones are the topical, which I know some people like a lot,
Mm-hmm.
creams, lotion, gels, patches, or sprays. That's my least favorite, and I'll tell you why in a moment. You
Okay.
have troches under the tongue. You have can have sublingual drops. You can have capsules, and you can have uh, shots, and you can have pellets, which I actually my favorite form. Let's talk for a moment about the topicals.
Okay.
Now, the topical cream, lotion, gel, patches. One of the main reasons I don't like them is that you can, when you put them on your skin, it's not exactly where you put it and how much you put on, so the absorption is different. The other reason I don't like it is because, well, it also based on the temperature outside, how much do you sweat, how much hair do you have, all that stuff blocks the absorption. Unlike any other form, the pills, the shots, and the pellets, you cannot do a blood test once you start therapy and rely on those levels of being a true and accurate reflection of what the levels really are. They're much, much higher.
If you are taking topical.
If you're taking topical.
Let me ask you one question there.
Yeah.
I don't want to interrupt your flow, but when you rub cream on, how long, this is a wife and husband question. How long is it active? Because he thinks that he's getting estrogen from me from
You're
wherever.
going to be in for a big thrill. You'll hear it coming up. It'll be the greatest story you'll ever hear.
Okay.
Okay.
How exciting.
No, yeah, it's going to be great. Wait till you hear this. Okay, so now you have this problem about the absorption, very erratic, how much hair do you have, whatnot. You cannot follow up the levels. You can follow up the levels if you do saliva or urine, but the problem is this, Suzanne. People pay a lot of money for insurance. Insurance companies don't honor what we do. So we ask people to do all these tests that are not covered by the insurance, and no matter what therapy you use, if a patient can't afford it, what good is it?
Right.
Doesn't matter. They have to be able to afford it. You have to look at the whole picture. What can they do? What is not so cumbersome? If they're going to be able to do it, if they can afford it. That's the best therapy. Now, I want to preface before I go on more about the topical stuff is if you are using a form that's working for you, should you continue? Well, only if you're not having side effects, but that's not enough. Again, absence of dis-ease doesn't mean the absence of disease. You need to make sure you're going to a doctor who understands metabolites, byproducts, right? Metabolites. Should I explain metabolites?
Yes.
Okay.
Yes.
Okay, so if you're healthy, you don't eat an apple and poop an apple.
Right.
You put gas in your car and turn your engine on and gasoline comes out the exhaust pipe. Byproducts, metabolites, right? Mm-hmm. So we know that testosterone and estrogen make different metabolites that often doctors don't check for. And if they don't, those are the things that can actually cause problems with cancers. I heard you speak one time with somebody and talking about testosterone and causing cancer. Well, we know that's ridiculous.
Right.
If that were even possibly true, how can you explain the total absence of a single case of prostate cancer in the world in a man under age 35? Never, right? So it's impossible. Something causes prostate cancer. What is it? Okay, so when testosterone is entered into the body or made within the body, we can aromatize that, break it down into metabolites through the fat in our belly, in causing something called estrogen, estradiol. This is when you see these men with the big bam boobs, no hair on their legs, all this problem, right? Now, that's one of the things that cause prostate cancer, estrogen. Now, that estradiol that was made from the aromatase enzyme in our belly from the testosterone converts it to something called estrone. Now, estrone is another type of estrogen that's very, very dangerous and never looked at. I have a paper I'm writing on that, and I'll share with you at some point in time. The other thing that causes prostate cancer is something called dihydrotestosterone, another metabolite of testosterone. Gave me my reverse mohawk, but also allows me to function in the middle of the night when I need to. Great stuff, right? But in too high levels, it's going to cause prostate cancer. Now, check this out. How does the testosterone convert into DHT? Through the hair follicles. You put it on your skin, it's going through the hair follicles, potentially converting into DHT, which it will. You can't check the levels. Doctors don't understand this. They say, okay, we have prostate cancer. No, that's what causes it. And now they have all these creams and lotions you put underneath your armpit, but where do you have more hair? Yeah. It's a long story to explain to you that sometime, but this is not a good reason. Another reason you don't want to use the topical. Here's another.
Or that you have a good waxer.
Yeah, there you go. Now, another thing about the topical is this. Now, years ago, all I knew was the topical. I trained Suzanne by some of the best in the world, and I was not getting the same results that all these doctors were after 18 months. So I said, this is crazy. I asked them what was going on. They didn't have any clues. So I decided I'm going to do some research, and I opened up a textbook, biochemistry, and I had an epiphany. I opened up the molecule of progesterone. As soon as I looked at that, I knew what the problem was.
Tell me.
Testosterone, estrogen, just like vitamin A, D, E, and K, are fat soluble. So what's the significance of that? If you put something on your skin It's got to go through the skin, eventually to the fat before it gets to the bloodstream into your tissues. It's not hard to realize if you have all this building up in the estrogen and building up in your fat that you can become estrogen dominant. You understand so far?
Yes, totally.
But it's a triple whammy. Because if a woman needs estrogen, she should be on progesterone and testosterone. Forget progesterone only to have a uterus. That's baloney. It's
Right.
Treat Company. You need all three. Did you catch that?
I caught it.
Thank you. Sorry.
And I like it. I might have to steal that.
You got it. You got it all.
Thank
So
you.
here it is. Here's the triple whammy. So if a woman needs estrogen, she needs progesterone and testosterone. Testosterone in both men and women converts into estrogen. Progesterone converts into every hormone in the body with the exception of the thyroid hormones. Triple whammy. More reason why I don't like the topicals. Another reason I don't like them. Excuse me.
And you're talking topicals for women and men, right?
Both, absolutely both, especially for the men with the prostate cancer. I've never seen a woman with prostate cancer, but if you see one, let me know. We'll write it up. Great story.
Well, she'll need her own bathroom.
Now, I know we're probably running down on time, and I have a lot more to say, but so I would like to sometime get another opportunity. You got to hear this story about why, when I started doing these topical, why my women weren't doing so well. I found out they were having classic symptoms of having too much estrogen, but their tests were normal. And I guess we probably don't have time for that now, but that is.
Tell the viewing audience, what were the symptoms of too much?
Okay, so they were getting too much and too little progesterone caused the same symptoms of bloating, the hot flashes that can cause that. They were getting bleeding, even though if they were 40 years old, 50 years old, I'm sorry, they were having a lot of problems with that, weight gain. Men would be getting problems with acting more like crying at chick flicks, that type of stuff, the man boobs, all those kind of things. But it's a great story, fantastic story of how it came about to figure out what's wrong. They were high in the levels. They were too high in the levels. And I wish I had time to talk about it because it's great story.
Well,
okay. You want to talk about it real quick? No.
I do. We've got time.
Okay.
It's very interesting.
This is a cool story.
Okay.
So when I was starting about 2 years into the practice, these women were having classic symptoms of too much, but I was checking the blood levels. I didn't know any better, and they were low. So I started checking urine, and they too were low, and then sometimes they'd be high. I said, I got to figure this out. What's causing this? I asked all these doctors. They couldn't figure it out. These women weren't doing the xenoestrogen problem. They weren't doing a lot of soy. I couldn't figure out what the hell was what. So I thought for a second. I said, my goodness. They're using topical cream, lotion, gels, patches with these hormones. How about other creams that they're using? These anti-aging creams. Is it possible that they have these hormones in it and it's not being told on there on the ingredients? Mm-hmm. So I called a good lab and I asked them if they'd be interested in sponsoring a study for me. And what I did over a period of 18 months, got about 450 different chemicals and anti-aging creams that I found out had DHEA, testosterone, progesterone, estrogen in it, and was never labeled.
Wow.
So in my big mouth in one of the ACAM meetings, I said something to somebody. I said, well, I'm going to be producing this paper and showing you what bad things some of these cosmetics are. I got home. A week later, I get this letter in the mail. It just had my name on it and typed in big letters, don't do it, with a CC to the lab who helped me do the study. I had no idea what the hell's this. I called them and said, listen, they're warning us. This is $1 billion industry. They're warning us not to do it, not to say anything. So now I continue to do those if I need to, but I don't tell the patient to tell me what it is. But I understand now that study has been printed about without our approval about 3 years ago. But that's what was happening to my women.
And what kind of hormones are they that are are they bioidentical?
Exactly. Well, yeah, that's a good question. We don't know.
Yeah.
We don't know. But when we have more time, I'll tell you my theory on that. Okay. So so now you want to get your husband's question about the
Larry King used to call that a grabber.
There you go. Yeah. Now here's the greatest story. Probably 10 years ago in one of my offices, I had this big guy come in with his wife, stack of papers, slams them down my desk. Says, Doc, I got to be assertive. Beautiful. With my ADD, I have to ask the questions in the same order, otherwise I goof it up. So I'm asking him all these questions. Look him right in the eye. His wife is answering every question. Assertive, this guy's whipped. I couldn't believe it. Finally, when I got to look at his wife and ask her what he did for a living, he decided he could talk. He said he's a coach. Beautiful. Look him in the eye, ask him a few more questions. He's batting his eyes to his wife. His wife continuing to answer all the questions until I get to the question about how's your stress level? How's his stress level? Well, he sticks out these words. Nobody in the world more stressed than I am, you know, with a couple other few fruity letters there. And I knew right then and there I had a perfect opportunity. I didn't have to be politically correct anymore. So I said, dude, I don't know what the hell you coach. He said, I'm a football coach. Beautiful. I went on to tell him how I was a high school wrestling coach and made some impact on kids' life, Christmas cards, and you get some phone calls. That's what it's all about, make a difference in people's lives. Right. Now his wife chimes in. Says, no, he's in the bigger leagues. I had no clue what she was talking about. Reason for the story will come in a second. So he's ready to leave. She's ready to leave. He says, Doc, you're a smart guy, but I think you're blowing smoke up my butt. Can you help me? Can you not? I say, I guarantee I help you. But you can help yourself more than anybody in the world. I'll do it. Whatever it takes, I'll do it. So you got to quit your job. Well, this big monster didn't like that. He got up off his desk this close to my face and tells me, I coach the New York Giants. Now think about a professional football coach telling you he's got to be assertive. This guy should be feared by God, for Christ's sake. Reason for the story. 6 weeks later, he comes back in. This has got to go in your book. This is classic. 6 weeks later, he comes back in. I'm looking at his hormone levels, his testosterone levels, which I want to be between 8 and 1200 or 200. I'm looking at his estrogen levels, which I want men to have estrogen between 15 and 35, 300. So I take his lovely and beautiful wife out of the room and ask her if she's going to any doctor who's giving her these topical creams, lotion, gels, and patches. She tells me, don't tell him to kill me. Kill him. You're making a sissy out of this guy. You wonder why he's got man boobs and why he cried because he ran over a squirrel on the way to a football game, right? So it was rubbing off her onto him. The answer is about 5 hours, okay? So what happened as I took him and her off that, he thanks me for saving his wife, his life, and his job, and I got great seats now. Yeah.
That's a wonderful story. Now, but what I want to know is, how is she getting her estrogen then? Are you injecting it?
No, I am doing pellets on her now.
On pellets.
I'll get to that. Yep.
So how often? You want?
No, go ahead. If you have a question.
How often does one insert the pellets?
Okay, I'll get to that.
30 days?
I'll get to that. Mm-hmm. No, it's much longer than that. So can I go on to the next form?
You may.
Okay. So the next after the sublingual is is after the topical would be a sublingual fecal flavored drops. These are wonderful, right? They taste nasty. Mm-hmm. You have capsules that you can do, which is the only form which goes to the liver, which may or may not be a good thing. Are you familiar with what's called first pass effect?
Yep.
Okay. Yeah. So I like giving progesterone orally because during that first pass effect, when the progesterone gets into the liver, it turns into a different form of progesterone, which causes drowsiness, and women fall asleep and they love you the first day. It's great. It's wonderful. But for other reasons, for other hormones, it may not be a good idea. Some people worry about blood clots forming because it goes into the liver, or they may have to be on other medications that are detoxified in the liver. So you may not want to do that.
And aren't our livers kind of groaning from all the chemicals and toxins? Does it make it hard for the liver to accept and receive hormones?
Groaning is a nice way to put it. Absolutely. Mm-hmm. Absolutely. Sure. Then we have...
That's another whole talk, isn't it?
Another whole talk, absolutely. Yeah. And then we have the troches, which are kind of like a hard candy. They're a lot better than they were before. Consistency of like saltwater taffy. You put between your cheek and your gum. Guaranteed to rot your teeth out. Start today by Halloween, shove a candle up your butt and smile. No need for a pumpkin. These things are wonderful, right? And then you have the shots, which the police officers love and the athletes love. And then, of course, the pellets. Now, I'm going to try to show a slide here and explain one more thing here. I want to
because in our house, Tuesday is my husband's shot day. Mm-hmm. And I must say, don't call us on Wednesday.
That's good. Mm-hmm. I hear you. Okay, so can you see this slide here?
I can.
Okay. Now.
Okay, we haven't got to suppository yet, but we got to.
Okay, so suppositories. Those are messy suppositories, rectal vaginal suppositories. Yeah. The only time I really use suppositories in women, if they have vaginal dryness, I'll use something called estriol, E3 cream, and they use it twice a week, and it's very, very effective.
And estriol is the anti-carcinogenic component of estrogen, right?
That is correct.
Whereas estrone and estradiol is carcinogenic.
They can be.
Estriol is so important. You're one of the first doctors who has mentioned estriol. So go on.
Very, very important. All of them.
I'm very impressed.
Thank you. So,
we've got the suppository.
Okay, yeah. So the suppositories. Okay. Now, can you see the slide here now?
Your IT guy is good.
Okay. You see the topical, oral, sublingual, suppository, and the troches. Now,
Yep.
the other, if a person wants to decrease the risk of heart attack, strokes, colon cancer, Alzheimer's, Parkinson's, and osteoporosis, mentally, emotionally, physically, sexually, globally feel better, what they have to do is they have to reach an optimal level.
Yep.
And that optimal level could be different for people. But not only do they have to reach the level, they have to maintain. They got to stay. They got to maintain. Did I say maintain?
Mm-hmm.
They have to maintain that level.
Mm-hmm.
Here's what I mean. Can you see this here? This is if you take any of these creams, lotions, gels, patches, a liver toxic pill, a crack tasting drop, a messy suppository, or a truth rotting troche, at 8 o'clock in the morning, the levels could creep up, and you may reach this optimal level, and you'll decrease your risk of heart attack, strokes, colon cancer, Alzheimer's, Parkinson's, osteoporosis for 2 hours. Then you can take your second dose. Up this, we got this roller coaster effect, right?
Right.
Not too good. Now, the next slide I'm going to show you is, could we give me the next slide, please? Oh, right here, I want to show this. Oh, that's not it. I'm sorry. Back, it's.
You're going to have to dock his pay.
Yeah, I want it back. No, another one before. Okay, here, this one here. Yep. Now, hot flashes. People erroneously believe that hot flashes are caused by low levels of estrogen. That's not true. If that were true, why don't 60, 70, 80, 90-year-old women who are postmenopausal, who don't take hormones, why don't they get hot flashes? Because it's not due to low levels. It's due to fluctuating levels. High to low, low to high, low to normal. Now, if a doctor is not skilled and knowledgeable enough and tells these patients, okay, we're going to put you on these hormones, and you're getting, see this fluctuation here, already here, what I talked about with the topical, the oral, suppository, and troches, you got these fluctuating levels. If you give any of these other forms, you are compounding those fluctuations, making the hot flashes worse. Now, I don't care about losing a patient. I don't need that much patience. I'm okay. But my problem is this. If I didn't explain it to the women and tell them they're going to get worse than the other hot flashes, they would not avail themselves later on after those hot flashes went away or they did another form of something that could truly decrease heart attack, strokes, cancer, Alzheimer's, Parkinson's, osteoporosis, mentally, emotionally, physically, sexually, globally feel better.
But let me ask you this. The fact that it's reaching peaks a couple of times during the day, is that protective?
Okay, I'm sorry. That is a bad diagram, and that's all we could put. It doesn't reach that thing. It doesn't reach.
Okay.
Now, how I believe, now can we go to the next slide, please? Now, the other options, okay, so here you see this, the graph of the topical, oral, sublingual, suppository, troches. Now, the injections. Here we go. The injections go like this. They start low, and then usually given into the muscle. I don't know if your husband's doing it into the muscle. Is that what he does?
Yep, that's where I put it.
Okay. So usually they go very high, and does he do it twice a month or once a week? How often does he do it?
Once a week.
Okay. So
that's why I said Wednesday is a very good day.
Gotcha. So usually, because a lot of doctors prescribe it and they do it, they come into their office twice a month or whatever. But anyway, they go high. They go above an optimal level. They usually, in this diagram, it's not really showing it that well, but they go above the optimal level and then they plummet. So instead of doing this roller coaster ride, they're falling off a cliff. They're not coming down hills, they're falling off cliffs. And the problem is when they get very high above the optimal level because of the dose they're using, so it lasts so long, they're converting into other metabolites that are potentially causing cancer and potentially causing the high blood pressure and heart attacks that is reported with the testosterone shots. Another great story to talk to me about.
Interesting.
Now, I devise a way, which I believe is better when you use the shots, that you do it subcutaneously, under the skin, like a diabetic needle. And unfortunately, I don't have a picture here, but if you can see my cursor here,
I do.
Happens, the levels come up like this, they drop a little bit, they come back up like a seesaw, like a what is it, a saw. See, like this.
So when you're doing it below the skin level, what like where's that on your?
In your belly, anywhere into the fat, like
belly.
Into like what a diabetic would do, anywhere that they would do. And you're getting those fluctuations, and you do it twice a week, about 100 milligrams. Yep, and it's wonderful. And you don't get those fluctuations. You don't have to wait on Tuesday, and you're already you all feel bummed out. You'll feel good the whole time, subcutaneously, like that.
Yeah, that's interesting. That's interesting because he's a little aggressive Tuesday nights.
Yeah, yeah. Well, there's other things for that. Now, is he being followed up for metabolites? Estrogen, estradiol, estrone, DHT.
Yes,
Are you
yes,
following all those levels?
yes. But that's why he thinks that my estrogen's rubbing off on him, because his DHT gets high.
Okay. Now, remember that can cause prostate cancer
I know.
over time.
I know.
Mm-hmm. Okay.
So here's my dilemma.
Yeah. Well, maybe we can convince you that maybe topicals aren't the best.
I'm paying close attention.
Okay. Now check this out.
Mhm.
Now the pellets is my favorite form, and they've been around for a long time.
Mhm.
We're in the right age group too. Maybe you remember what was called the Norplant. It was a form of birth control right into the forearm. Very similar. These pellets are surgically implanted into the fat of the tissues that will absorb over a period of maybe 3 to 4 months in women, 5 to 6 months in men. And
Okay, let me do devil's advocate for 1 minute here. Did nature ever give it all to you all at once, like that?
No, I'm glad you're asking this. No, it did not.
Did nature just like release it in little increments, all 24 hours a day?
Yeah, that's true. That's true. In my experience, what's most important to people is to feel well, and when they would much rather have those levels that are sustained high than to go the ups and downs like you see on these graphs. Can you see me, or are you seeing the graph?
I'm seeing you, me, and the graph. It's wonderful.
Beautiful, beautiful.
It's
okay.
a wonderful thing. I just can't see your IT guy.
Okay. Now here's the deal. The only time that I would not use pellets is in a young man who wants to maintain their fertility. That expression, if you don't use it, you lose it. If you don't exercise, you lose your muscle.
Yeah,
you have sustained levels, and I'll show you what I'm talking about. Here's what the pellets do, I think. Okay, so the pellets slowly increase over a period of 3 or 4 weeks, and then they maintain that level and slowly decrease as the gas runs out.
Right.
Now, an important thing to remember is the difference between a poison and a medication is the dose. The dose of testosterone or estrogen, if you did this form, the pellets versus the other form, is 1/20th over that period of the 4 months. Much, much, much better that way. Now, getting back to the sustained levels. So if a young man has sustained levels, his brain, FSH, LH, are going to say, listen, I don't need to make testosterone because there's plenty of it there. So the testicles will shrink, we'll have all these problems, and then we may have some problems with fertility, or infertility, I should say.
Yeah.
So those men, I don't. But with everything being relative, see this little one here that I'm got the cursor on? These ups and downs. Now, could you imagine if this was you before you started doing hormones, Suzanne? Right? Okay, right here. Okay, those are your low levels and high levels. If you did another form that got really, 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 really high, and your lows were the same, how badly you would feel?
Yes, I see that.
Yeah, everything being relative. So this is, again, a reason why I don't like these 5 right here. Now, again, I think
Now, is this what you take in that first hour and a half? You give your patients, or longer, whatever it takes. Is this what they get to?
All of this plus neurotransmitters and adrenal glands. My heart program.
This is wonderful. This is the most comprehensive explanation of any doctor I've ever interviewed. Really, this is really wonderful. We're running low on time, and we should talk again. What do you mean good? It's not good. We're running low on time. Here's what I don't know. What's too high? Who decided here's the maximum amount of hormone? If every person is an individual, and our needs are individual, and our stress levels are different. I go on for a living, so that you have stressful moments. What's too high? Like my doctors always say my estrogen is so high, but I feel amazing all the time. So I just go, to me, my point I'm making is it not the number, but having your ratios right?
Absolutely. Ratios are very important as well, but so are the levels, because we know that a lot of the conventional studies are based on ratios plus levels of thousands of patients. Everything that I shared with you, I can show you medical studies, conventional medical studies, that back up every single thing I say.
Well, we should talk again. This has really been great. I think any patient who gets to go to you is lucky to get such a comprehensive explanation. If you walk in and you don't know anything about this, you're going to walk out being educated. And what a great service you are doing. I'm really impressed with you.
I thank you very much, and my goal is like yours. I want to be able to provide all patients with these complementary and alternative services. So everybody who needs it, everybody wants it. You've done a great job in informing all these people, but the problem is there's not enough practitioners providing it. So my goal is to train as many physicians as I can, and even if that means to change how in America how healthcare is given. And I don't care if that's one patient, one physician, one condition, one life, or one day at a time. God darn it, I'm going to do it. I need your help.
I'm there for you. I thank you so much.
Thank you.
All right. Make sure, all of you who are watching, if you're in the Manahawkin, New Jersey, Wayne, New Jersey, or Medford, New Jersey, you go to see Dr. Mark Bartiss.
Thank you, Suzanne. Look forward to talking to you again.